Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Pediatric Dentistry Workforce Study, Origins, Results, and Policy Implications. And it was presented by Paul Casamassimo, Tim Dall, and Margaret Langelier on September 9th, 2019.
So I'm going to go ahead and start with the intro, and then I will turn the event over to Paul. Hello, my name is David Armstrong, and today's webinar focuses on a pediatric dentistry workforce study that was recently completed. Our presenters are Paul Casamassimo, Tim Dall, and Margaret Langelier.
Hi, everyone. It's Paul Casamassimo. I am the Chief Policy Officer at the American Academy of Pediatric Dentistry and was involved in the planning and conduct of this study. So I wanted to just give a brief overview of the study, why we did it, and where do we go from here before our other presenters talk. So the first question is, why did we do this study? We all were aware that the number of pediatric dentists have grown or has grown, and we've seen an increase in the number of training programs and the number of graduates who are pediatric dentists in this country, yet surveillance suggests that some of the disparities that we know exist in disease in children continue. So we felt that it was important to get a better understanding of the relationship of pediatric dentistry to health disparities and their elimination. So we also, some evidence suggested that more treatment is being provided to young children in the years past, and the evidence both here and abroad would suggest that general dentists don't necessarily want to care for very young children, and I mean children under 5 years of age. And the rate of dentists taking Medicaid, which serves many underrepresented groups, is low. So we were trying to understand that seeming paradox and find out whether it was pediatric dentists who were in fact responsible for that or not. We also were aware that previous studies, some of our own and others, suggest that pediatric dentists fill a niche in the oral health care system that no other group or groups address, one being taking care of Medicaid patients, and the other is taking care of people who have disability. So, and then the last reason was, quite frankly, nobody was really looking at this increase in number. No one was really paying attention as far as pediatric dentistry was going to the changes in population and where those changes were taking place. So those are the reasons why we felt it was necessary to invest in a study like this. So, you know, why are we worried about this? Well, we want children's oral health to continue to improve. There are still disparities out there that need to be taken care of, and so we felt it was important to do the study. The other part of it, which is not necessarily appreciated by everyone in the care system, is that a healthy pediatric dental workforce means healthy children. So if we have too many or too few and not the right number, that ultimately filters down to pediatric oral health and negative or positives depending on the balance of the workforce. We also know, and you are probably aware as I am, that we have an election coming up. We'll probably see some form of healthcare reform, and we want to be prepared to participate in that discussion and be prepared with data, not just opinion, or even worse, be perceived as trying to stifle improvement. So then a very pragmatic reason, and this should speak to everyone who is a taxpayer, is that the Title VII program has funded many of the increases in pediatric dentistry training programs and hence graduates. And we felt it was only responsible to look at that program and say, do we need to continue? Do we need to direct it in a different way to maybe get our graduates, pediatric dentists, into other areas or doing different things than right now? So we felt a responsibility and accountability to look at that program, which really has benefited children and our specialty. And then the last thing was, and this will come up in the future, that we tend to look at solutions to dental disparities as simply making more dentists, making more alternative providers, putting another clinic out there. And in fact, we wanted to find out if that is in fact the case, whether we need to be moving past numbers of providers and looking at things like health literacy and so on. So after this study was published, we are already busy looking at what to do with the results. And the first part is a thorough review of findings and discussion of policy implications and other issues. And we encourage every community out there with an interest to participate in that discussion. We want to come up with a plan for the future. Do we continue to train the numbers that we have, or do we do something different? And we're not sure what that is, but hopefully we will digest the material that we have from this study and move forward. We plan to look at our programs and continue surveillance of the system and disease and how people are utilizing the system in the future and relate that to the findings of the study. And then make adjustments as an organization in our advocacy, legislative, and treatment approaches as needed to continue excellent care given by pediatric dentists. I think that's the next slide. That's it.
Okay, thank you, Paul. Next up, we have Tim Dall.
Great. To start off, I just want to acknowledge that this modeling work was a team effort, and the results that I'm presenting today are actually also written up in an article that was published recently in the Journal of the American Dental Association, and would invite people to go see the article for more information on this study. So Paul has laid out the background and purpose of the study. The purpose is very straightforward: assess whether the current and anticipated future supply of pediatric dentists is adequate to meet demand, both at the national level and geographically, in particular across states. We know that there is large levels of unmet need for care and large numbers of children with caries, and we understand the importance of overall good oral health in terms of people's overall health and quality of life. When we look at the American Dental Association master file, only about 3.9% of dentists are pediatric dentists, although general dentists provide a large proportion of the care to children. Before I get into the data and methods and findings, I just want to clarify two definitions. One is demand and one is need. When we talk about demand, we can talk about the demand for oral health services and also the demand for certain types of providers. But when we're talking about demand, we're estimating the level of care that patients are likely to receive based on their ability and willingness to pay for services. So it takes into account the price of services as well as people's underlying need and other factors that might influence whether or not they receive care. Alternatively, we have a definition of need. Need is defined clinically based on guidelines of what services children should be receiving, both in terms of preventive care and treatment. And need is very challenging to model. So what we model is demand. And the importance of modeling demand is that we want to train a workforce that is able to provide the level of care that people are likely to be seeking rather than some level that might not economically be feasible. The study consists of 4 components: a survey, modeling effort, literature review, and interviews. I'll be presenting a little bit of information from the survey as it affects the modeling, but I'll be focusing most of my discussion on the modeling of future supply and demand. I would note that the computer simulation model that is used for this study is also used for a variety of other types of studies. It's used by the federal government to look at demand for oral health providers and physicians and nurses and other health occupations. And it's a model that's been published and validated and reviewed extensively. The way the supply model works is you start off with the current supply, and each year we model the number of people likely to leave the workforce through mortality and retirement, and the people that don't leave the workforce continue to the next year. We model the number of new entrants coming in and the demographics of the new entrants, their age, their gender, their race, ethnicity, and we use that information to estimate the starting year for the next year, and then this cycle repeats itself. When we model demand for providers, we first start by developing a representative sample of the child population in each state from 2016 through 2030. And for each person, we know the demographics, we know some information about health risk factors and lifestyle choices, insurance status, and socioeconomic information, in particular household income. And we use analysis from the Medical Expenditure Panel Survey, the MEPS. The MEPS collects data on a representative sample of the population. And for each child in that population, we have information on the number of times they went to see a dentist during the course of a year and the types of services that they received. And so that's how we model the demand for services, where the demand is related to the factors in the population file. And then once we model the demand for services, we can look at staffing patterns of how the oral health system is providing those care, and we can get demand for providers. And with both the supply and the demand, we can change assumptions and key parameters to better understand the sensitivity of the projections to changes in parameters. And of course, there is uncertainty about whether certain trends will continue, and so we can model those scenarios. On the supply modeling, we start off with an estimate that there are 6,530 pediatric dentists in the U.S. in 2016 who are active in the workforce, and about 448 people that are in new positions or new dentists that are entering the workforce each year. Quite a few of these, 63.6% are female, and then of course we model an age distribution based on recent graduates from the program. From the survey that was conducted, we have information on pediatric dentists' work hours, retirement intentions, and some other information about how busy they are and their perceptions about whether the supply of pediatric dentists is adequate. And this information is incorporated into the supply model. We look at some migration of dentists across states, although we'll note that after a dentist completes their training and enters practice, there's relatively little migration from state to state. And then for supply, we model different scenarios. One is the status quo scenario, which is if we continue to train the same number of pediatric dentists each year that we're training now, and if hours work patterns and retirement intention patterns don't change, then what is likely to be the future supply in the future? And then we model, well, what would happen if we increase or decrease the number of new pediatric dentists trained each year? What would happen if dentists retire earlier or retire later by plus or minus 2 years? And part of the reason for this is we know that from year to year, retirement patterns can change, sometimes to reflect economic conditions. There's a concern in the health workforce in general about burnout. So we model how sensitive the supply projections are to retirement. And because the demographics of the dentist workforce is changing over time, we define a full-time equivalent based on working 32.6 hours per week in patient care activities. This reflects the average patient care hours worked from physicians that participated in the survey. On the demand modeling, we also model a status quo scenario, and this scenario assumes that current patterns of going to the dentist continue over time. That is, it varies by age, it varies a little bit by gender, it varies quite substantially by race, ethnicity. with minority populations having lower use of care. It varies by whether you have insurance and household income and living in a metropolitan area. And so we apply these prediction equations to our future population, and also we model that the delivery of care will remain relatively constant over time, which is that pediatric dentists currently provide approximately 43% of the dental care that are provided to children under the age of 2, about 40% of the care provided to children ages 2 to 4, 23% of the care provided to children over age 5, and this is based on analysis that the American Dental Association has done with their practice survey, and they provided us this market share information. So when you combine these, we estimate that about a quarter, 26% of the dental care provided to children is provided by pediatric dentists, with the remainder provided by general dentists in a family practice setting. So the status quo assumes the continuation of this market share. We also modeled an increased market share scenario, and this was based on input from an advisory group. And that recommendation was that for children under the age of 5, about 80% of the care really should be provided by a pediatric dentist. And then for children between the ages of 13 to 17, about 20% of that care, it would be appropriate for it to be provided by a pediatric dentist. And so that would approximate that 62% of care to children should be provided by pediatric dentists rather than the current number of 26%. So this was just a hypothetical scenario. And then we modeled another hypothetical scenario, recognizing that certain populations, in particular people without insurance, lower income, people in racial and ethnic minority populations, do have lower access to care, lower use of care, and we think that is largely due to access barriers. Those access barriers could be supply barriers, they could be financial barriers, they could be literacy barriers. But if we could implement policies and programs to help achieve some of the national goals around oral health as specified by the Healthy People 2020 goals and reduce those disparities in care, what would be the increase in demand for services? This somewhat approximates a needs-based scenario, but it's not exactly a needs-based scenario. One of the bits of information that we needed from the survey was to ascertain whether the current workforce was adequate and whether we needed to increase our staffing ratios to reflect that there was undercapacity or decrease them to reflect that there might be overcapacity. And so in the survey, pediatric dentists were asked whether they perceive the current supply in their area to be a shortage or adequate or oversupply. And in this table here on the left, you can see some of the responses. In the Midwest region, 16% said there's a shortage of pediatric dentists, but close to 61% said no, we think it's adequate, and 23% said that there's an oversupply. And the regions with the largest proportion saying an oversupply were the Northeast region at 48% and the West region at 54%. And so in these two regions, we have half of the pediatric dentists saying that there's oversupply and a much smaller number saying no, there's a shortage, and a large portion saying it's adequate. We looked at this information by population density, and this question was, do you perceive that in your state, in the less populated areas, there is an inadequate supply of pediatric dentists? And for those pediatric dentists working in population centers with low population density, a large portion of them said, yes, there is a shortage. And as we got to areas that were more highly populated, they again, by and large, agree that yes, in the less densely populated areas, there is a shortfall. But the Northeast region and the West region were the ones where they thought there might be an oversupply. So when we go to this next slide here, this shows the pediatric dentists per 100,000 children. At 9 per 100,000 is the national average, and the blue areas represent those numbers greater than 9, red areas less than 9. And so we see in the Northeast there is an abundance of pediatric dentists, in those states relative to national average, and in the Northwest, there's high numbers, and here in the Midwest and South, we see numbers that are substantially below the national average, and that again is where there was a perception that there was inadequate supply. Now, one of the challenges with surveying people is that if you have a pediatric, well, most pediatric dentists are in urban areas, and so those are the areas where they might say, yes, we have an abundance of pediatric dentists. And if you don't have a pediatric dentist in a particular rural area, there's no one to respond to the survey and indicate we don't have enough pediatric dentists in our area. When we look at additional measures of how busy people are, one of the questions that was asked was, were you able to treat all the patients that came to see you or not? And we see that in 2016, 57% said yes, we were able to treat them, but and we're not overworked. Another 15% we were able to treat, we were not able to treat them. We could treat them all, but we were feeling overworked. And these numbers, at least for the treated but not overworked, seems to have increased between 2011 and 2016. When we look at the information by population density, what we find is that in rural areas, where they say I'm too busy to treat all the people requesting appointments, that was about 15.7%, and that number declines substantially as we get to the more densely populated areas. And then the first row here on this right-hand side table, I could provide care to all who requested appointments and I was not overworked. Those numbers are pretty constant at between 55 and 60%, regardless of density. So with all this information, there really was very little information to say at the national level there's a shortfall, even though there's clear indications that within a geographic area, in particular rural areas, that there was inadequate access to supply. When we model the supply growth under the status quo scenario, we model that it will grow by a little over 4,000 full-time equivalent pediatric dentists between 2016 and 2030, with the numbers ranging from a low of 3,400 increase to 4,700 increase as we change some of the scenarios and assumptions about the number of new pediatric dentists entering the workforce and retirement patterns. When we look at the change in demand, under the status quo scenario, which is looking at population growth, we estimate that over this period, the demand for pediatric dentists would only grow by 140 pediatric dentists based on population growth alone. And the reason is the U.S. population of children is relatively stable. It's only growing by a little over 2.5% over this time period. And much of that growth is among minority populations that historically have had lower rates of visits to a dentist than, say, their non-Hispanic white counterparts. When we model the scenario about removing access barriers, what we estimate is that would increase demand by about 2,100 pediatric dentists. And then under the scenario where the pediatric dentists could increase their market share to the levels recommended by the advisory panel, that would increase the demand by almost 10,500. What this suggests is that the demand for pediatric dentists is really not going to grow because of changing demographics. It's going to grow to the extent that the health system can advocate for policies and programs to improve access to care. And in the case of pediatric dentists, if a larger portion of care to children was provided by them, but that could come at the expense of other dentists, in particular family dentistry. So when we compare these numbers here, down here in the bottom of this chart, we see this growing gap between the supply of pediatric dentists and what would happen if they maintained their share of the market. We model what would happen under the improved improved access scenario. And then jumping up here to the 16,500, this is what would happen if the pediatric dentists were to achieve the market share rates for children that was recommended by the advisory panel. And then these top two lines just reflect the total demand for dentists for children, whether that is provided by a pediatric dentist or a general dentist. This shows what the entire market size is. So in conclusions, the supply of pediatric dentists continues to grow rapidly, whereas the demand for dental care by children is growing very slowly, reflecting low population growth, and that for the demand for pediatric dentists to grow, if we make an analogy with the pie, we either need to grow the size of the pie or redistribute the pie. And there is a substantial interest, I think, at the national level in improving access to care, as reflected by national goals such as Healthy People 2020. But obviously, there are many financial challenges to achieving that goal. Not presented in the modeling, but a few key findings from the survey is just a reflection that the oral health system is changing through practice consolidation that could provide efficiencies. Those efficiencies, to the extent that they increase provider productivity, could dampen demand further, to the extent that if each dentist is providing more care, you can get by with fewer of them. Also, the gender composition of the workforce is changing, with more women entering the workforce, the pediatric dentist workforce. And the survey highlighted that female pediatric dentists are more likely to want to go to an urban area rather than a rural area to practice. And that the profession is poised to be able to provide, have a sufficient supply to provide care to low-income children. Again, the major challenges there are those that are financial. So with that, David, I'll turn it back to you.
All right, thanks, Tim. Next up, we have Margaret Langelier, and she's going to be discussing some of the policy implications of this study.
So good afternoon. I'm just going to quickly and briefly summarize some of what's already been said by both Paul and Tim, and just give you a sort of view from 1,000 feet about some of the policy implications for this study. So what did we find? I think that this study showed that there are important things happening for pediatric dentists specifically, and for the oral health service delivery system generally. One of the things that the study certainly showed is that the federal support for residency training of pediatric dentists has really contributed to an improved supply, and we've certainly addressed some of the past concerns about the inadequate supply of dentists who are specifically trained to work with children, and especially those with special health care needs. So as Tim suggested, the study approximated a sufficient supply currently and an increasing supply of pediatric dentists in the future. So as a result, the oral health delivery system really is much better positioned to provide dental homes for children beginning at age 1, and this is an important policy initiative that's been emphasized over recent years. The current supply also suggests both current and potential capacity to improve access for children with special health care needs, and we know from education surveys that the rates of disability or diagnosed disability among children are increasing, especially in certain diagnoses like autism. So pediatric dentists will be critical for those populations. We know that pediatric dental workforce increased proportionally more rapidly than almost any other dental specialty over the past few years, and that it is now more gender and racially and ethnically diverse in the past, and younger on average than dentists generally, which is good news because we continue to worry about the retirement rates in the general dentist population. And while the numbers were very, very positive in the survey, as Tim has just suggested, there is nuance in the numbers. While current national supply is adequate to meet relative to current demand, there is a shortfall of pediatric dentists in certain geographic areas and an uneven distribution relative to the population of children especially considering where growth in the population of children is occurring. So what are the policies and programs that should be considered to encourage pediatric dentists to locate practices in underserved communities? So some of them are that we want to continue to encourage dental loan repayment incentives at the state and national level. We want to perhaps redirect more funding to support residency programs in community and public health settings where high needs patients often receive services and where the increased demand will likely emerge. And we want to encourage alternative modes of service delivery. So some of these might be teledentistry. There's currently a very large program here in New York using a pediatric dental specialist in conjunction with an FQHC that does a lot of teledentistry services for children under 5. We want to encourage mobile and portable dentistry services, allowing itinerant care to bring the services to WIC programs into schools. Many of those services can include a pediatric dentist on an occasional or periodic basis. And the other thing that's happening is we're seeing that group models group practice models are increasingly prevalent. About 42% of pediatric dentists were working in a practice with 3 or more dentists. Some of these are dental service or dental management organizations that seem to have improved ability to locate practices in areas that have not in the past been able to support dental practices. So we're hoping that some of these changes and alternatives, and certainly policy initiatives that support them, will increase the availability of pediatric dentists to patients. The other thing that I think that this study shows is that we have an opportunity here to impact demand. Now that we have what appears to be sufficient capacity, we need to continue to increase the oral health literacy of parents about the importance of children receiving services at the standard of care. So we know that in any year, only about 50% of children on Medicaid and just a little over 2/3 of children with dental service receive any dental service in a year. And this is certainly not consistent with recommended standards. So we think that it's very important when we're considering programs and policy to improve health and oral health literacy among both parents and children in schools, certainly. The efforts to educate parents to bring children at age 1 or at first tooth eruption are very important. We know that 75% of parents with children at that age still do not bring their children to the dentist. And especially as we move to value-based care and to wanting to improve oral health outcomes over the lifetime, this entry point is particularly important. So again, increasing the oral health literacy of parents. The other thing is that growth in the population of children in the U.S., as Tim mentioned, is mainly among populations that are traditionally underserved, including low-income people, where oral health literacy may not be at the standard that we'd like. So what are the implications for the delivery system generally? I think it's important to realize that pediatric dentists do not work in a vacuum. They're working in a delivery system that includes lots of other dentists. And there's going to be impacts of the workforce growth in those other specialties that will impact pediatric dentists. We know, for instance, that the supply of general dentists is growing more slowly than in the past. And that may lead to increased reliance on pediatric dental specialists to meet the needs of children. The debt burden on general dentistry is significant and has been discouraging participation with public benefits programs, and that may continue. And we know that pediatric dentists serve on average more Medicaid-eligible children than general dentists do. So those sort of economic pressures could further push utilization of pediatric dentists. We certainly need to support continuation of Medicaid and CHIP benefits as a minimum at the minimum standard of care that currently exists, and we certainly want to continue to encourage states to reimburse those services appropriately. I think both the growing emphasis on prevention and value-based care in medicine and dentistry will encourage early and ongoing preventive care, again, driving demand for pediatric dentists. And another thing that we need to consider is at the other end of the spectrum, the aging of the population may increase demands on general dentists and shift care a little bit, since older adult population may need more oral health care in the future, leaving less capacity within that population for children. So there, again, there's a number of larger things happening within the workforce that could impact how and where pediatric dentists are needed.
All right. Thank you, Margie. So we'll go ahead and wrap up this webinar. Thank you, Paul, Tim, and Margie, and thank you and the audience for attending today's event. We hope to see you again in the future. Have a good day.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.